difficult to treat rheumatoid arthritis. A renowned rheumatologist from Aga Khan, Hafiz, Mehmood, Riaz.
Assalamualaikum, ladies and gentlemen. It's a pleasure indeed to interact on the Park Orthocon forum with highly skilled and intellectual experts of orthopedic surgery. And I'm thankful to the Park Orthocon organizers to provide me this opportunity to talk about difficult to treat RA on this forum. So let's start. Here is my disclosure. I have no current and past relationship with commercial entities, and I have received no speaker's fee for this learning activity. How we define difficult to treat RA? Difficult to treat RA is defined as failure to two or more than two biologic targeted synthetic DMARDs with different mechanism of action after failing conventional DMARDs with an ongoing active and progressive disease, which can further divide one or more of the following. The first is moderately active disease measured by the DAS28. The second is inability to taper glucocorticoids below 75 milligrams per day, prednisolone or equivalent. The third is the rapid radiographic progression, and fourth is the poor quality of life despite all controlled disease. As you know that the goal of therapy in rheumatoid arthritis is to achieve low disease activity or to accomplish remission. Remission is hard to achieve in rheumatoid arthritis. And this goal can be accomplished by inhibiting the radiographic progression and hence by preventing the irreversible joint damage and to inhibit the functional disability, the chronic pain, the early employment, and poor quality of life. Are you able to hear me? What are the rates of remission in rheumatoid arthritis? The rates of remission in real life did not exceed 20% actually. And 50% of all patients discontinue their anti-TNF treatment during the first 3 years of life. The reason might be the primary failure because of ineffectiveness of the first disease, because of the first anti-TNF treatment during the first 2 years. Minority are truly difficult to treat following multiple disease-modifying anti-rheumatic drugs with different mechanism of action, posing a significant unmet need in the rheumatoid arthritis field. So let's review a case of difficult to treat RA and see that how we can able to offer a treatment which is feasible for that specific patient. A 75 years old female who was originally diagnosed seropositive RA, age 46 years, with past medical history of thyroidectomy for hyperthyroidism, diagnosed with monoclonal gammopathy of unknown significance in 2006. She failed several conventional DMARDs, including methotrexate, cyclosporin, azathioprine, sulfasalazine. Due to GI symptoms, managed to maintain prednisolone at doses varying from 5 milligrams to 15 milligrams per day. In 2001, she was treated with leflunomide with an initial good response, but by 2003, she developed severely active disease, despite 20 milligrams of leflunomide and 15 milligrams of oral prednisolone. Her DAS28 score was 5.4 at that point in time. She commenced on etanercept which is an NTTNF, 25 milligrams twice weekly in September 2004. She had initial improvement in DAS28 to 3.1, but developed secondary loss of response within a year. In 2006, she had a primary non-response to treatment with adalimumab, which is another NTTNF. She was treated with rituximab, an anti-CD20 therapy, in combination with leflunomide as a part of clinical trial in 2006, but lost response and developed hypogammaglobulinemia after 3 cycles of rituximab. She subsequently commenced treatment with intravenous tocilizumab, which is an interleukin-6 inhibitor, responded well to tocilizumab and maintained a response after a number of years before developing a secondary failure in early 2017. She was subsequently treated with abatacept, which is T-cell co-stimulation inhibitor, but had no improvement in her inflammatory arthritis and developed cellulitis and mouth ulcers, so she stopped that treatment as well. In late 2017, she presented once again with severe active disease. She had significant pain and swelling in both hands with wrist and both elbows. She felt fatigue and systemically unwell. On examination, synovitis can be appreciated along the PIP and MCP joint of both hands, both wrists, both elbows, and effusion in her left knee. She was pale, but her systemic examination was otherwise unremarkable. Disease activity assessment revealed tender joint count of 26, swollen joint count of 25, and visual analog score of 100 by 100. C-reactive protein was 56, so the calculated DAS28 score was 8, suggestive of severe rheumatoid arthritis disease. Her other blood tests were unremarkable other than hemoglobin was low. So taking this case into consideration, who has failed several conventional and biologic disease-modifying antirheumatic drugs, according to the guidance of the ULR, in the first stage of if your patient actually failed therapy to conventional disease-modifying antirheumatic drugs at 3 to 6 months, then you need to switch to your patient to a biologic disease-modifying antirheumatic drugs. But the new option in this case here is the JAK2 inhibitors. So if your patient would improve on either a new biologic, which in our case, the patient was actually failed to multiple biologic therapies, so she seems to be a candidate for JAK2 inhibitors. Let's review the latest guidelines which are published by the ACR, American College of Rheumatology. These guidelines were published in July 2021, and they are also actually indicating the use of targeted synthetic disease-modifying antirheumatic drugs in insufficient response to methotrexate. If you review the NICE guidelines of the UK, they also inform us that tufasitinib with methotrexate is recommended as an option for treating active rheumatoid arthritis in adults whose disease has responded inadequately to intensive therapy with combination of conventional DMARDs only if the disease is severe, which means that the DAS score is more than 5.1. In our patient, the DAS score was 8. R cannot have another disease-modifying antirheumatic drugs, including at least one biologic disease-modifying antirheumatic drugs, and have a DAS 28 more than 5.1. That patient cannot have rituximab. But our patient has tried even rituximab, which failed in her case after 3 cycles. Tufasitinib can be used as monotherapy for adults who cannot take methotrexate because of its contraindication or because of an intolerance. So the treatment of this patient was commenced with tufasitinib 5 milligrams twice daily in combination with 10 milligrams prednisolone. She had a rapid improvement over the course of the next few weeks. She suffered from side effects of nausea for the first 4 weeks, but this subsided without any intervention. After 8 weeks, the treatment, she developed a lower respiratory tract infection and required a course of antibiotics. She was able to restore tufasitinib after 2 weeks without further complications. So if you look at the outcome of this patient, after 3 months of treatment, the patient arthritis has improved significantly. She felt systemically well. Steroid has successfully been weaned on to 5 milligrams daily. There was continued evidence of synovitis of the metacarpophalangeal joints and the proximal interphalangeal joints, but this was much improved. Her C-reactive protein has reduced to 19 milligrams, and her DAS28 score had improved to 5.4. After 6 months, the DAS28 was 3.383, and the visual analog score was 40. The C-reactive protein was down to 12.6. So this is how the treatment can be personalized depending upon the challenging cases of long-standing rheumatoid arthritis. So according to the new guidelines of the ULR and the American College of Rheumatology, as well as the NICE guidelines of UK, the targeted synthetic disease-modifying anti-rheumatic drugs is another choice which can be used in these kind of patients. So JAKs are the first targeted synthetic DMARDs licensed for the treatment of RA with comparable efficacy to biologic disease-modifying anti-rheumatic drugs. Unlike the single cytokine targeting approach of the biologic DMARDs, JAKs are specifically designed to inhibit intracellular signaling molecules common to the receptors of multiple inflammatory cytokines implicated in the rheumatoid arthritis pathogenesis. So let's see that how the biological effects of the JAK inhibitors are achieved. So there are multiple cytokine receptors on the cell membrane, and through the JAK-STAT pathway inhibition, these cytokines can be inhibited and can lead to an anti-inflammatory actions that will actually improve the overall activity of the disease. If you compare the JAK inhibitors with the biologics, you would see that the administration site is the JAK can be taken orally, and the biologics are used either in the form of a subcutaneous injection or intravenous injections. Biologics actually act on 1 or 2 cytokines, and the JAK actually inhibits multiple cytokines and is considered to be more effective drug as compared to the biologics. The dosing frequency is also convenient. It's daily per oral tablet, 1 to 2 daily. And the biologics are given weekly or every 4 weeks, even monthly. So if you look at the time to clinical response, the response to JAK inhibitors is quite often over 2 weeks. You would be able to appreciate any improvement over 2 weeks. And in case of biologics, it's typically not immediate. Biologics can produce immunogenicity, which means that over time you can have secondary failure to biologic therapy, which is highly unlikely in case of JAK2 inhibitors. If you look at the duration of the effect, the biologics have a long life and immunomodulatory effect. The JAK inhibitors have a short half-life, and immunomodulatory effects rapidly decrease when we discontinue. Let's review the data of the efficacy as far as the efficacy and safety of the JAK inhibitors. There are several trials which have been done to prove the efficacy and safety of JAK2 inhibitors in the treatment of rheumatoid arthritis, and these are listed over here. 4 JAK inhibitors have been licensed for the treatment of rheumatoid arthritis, including tofacitinib, baricitinib, abatacitinib, and the filgotinib. And there are several trials, and we will actually look through few trials as far as their efficacy is concerned. If you look at the tofacitinib trial, which is oral step versus placebo, it's a 24 weeks duration clinical trial, and the dose of tofacitinib was 5 to 10 milligrams BID along with methotrexate. Nearly 400 patients were recruited, and the primary endpoint was ACR20, HAQ Disability Index, and the DAS28 ESR less than 2.4. And similarly, there are other trials which were done for the baricitinib, which is rheumatoid beacon, abatacitinib, which is the select choice, and select beyond, and the filgotinib, which is the FINIC2. If you review the results of the oral step clinical trial, you would appreciate that at month 3, ACR20 response was achieved in patients who were receiving tufasitinib 5 milligrams twice daily at 10 milligrams twice daily in up to 41.7% and 48.7% patients as compared to the placebo. Similarly, the ACR 50 response was actually 26.5 with a significant p-value for 5 milligrams twice daily and 27.8 for 10 milligrams twice daily versus placebo. If you look at the disease activity status, 14.3% of patients who were receiving tufasitinib 5 milligrams have achieved DAS20 at 3.2 over 3 months and 20.8% over 6 months. Let's review the results of the clinical trial which was done for baricitinib. It was an international multi-center randomized double-blind active control phase 3 clinical trial. Included more than 500 patients. At least 30% of patients were actually showed non-response to more than one biologic disease-modifying anti-rheumatic drugs, which was NTTNF, and more than 50% of patients had shown no response to more than 2 biologic disease-modifying anti-rheumatic drugs. So if you look at the ACR responses at week 12, you can appreciate that the ACR 20, ACR 50, and ACR 70 responses were significantly higher as compared to the placebo when you compare the baricitinib in 2 milligrams and 4 milligrams along with methotrexate. If you look at the results of the SELECT and Beyond, which is the apadacitinib plus methotrexate in biologic DMARDs and inappropriate response in RA, you can appreciate that the ACR 20 response was achieved in almost 65% of patients at week 12. And similarly, if you look at the apadacitinib 15 milligram dose with methotrexate and 30 milligrams with methotrexate, you can appreciate the week 12 and week 24 results, which has more than 50% of patients achieved these responses. So in the interest of the time, I would like to skip this, but I would like to discuss 1 or 2 more slides, which are actually showing that whether the JAK inhibitors can be used as a monotherapy or not. So this is the oral standard and scan clinical trial, which actually was done with tufasitinib and methotrexate. In methotrexate, inappropriate response RA patient. And if you look at the results, you can see that the ACR 20 response at 6 months have shown more than 50% response in 5 milligrams and 10 milligrams of tufasitinib group as compared to the adalimumab with methotrexate group.
We are 5 minutes over, Prof.
All right. So I was just actually wanted to discuss with you that the JAK inhibitors can also be used as monotherapy, and there is a building evidence to suggest that the JAK inhibitors are considered to be an alternate to the methotrexate therapy at this point in time as well. So if we leave over here and go to the safety data, just only one slide, I would like to say that this is the safety data of the JAK2 inhibitors, and you can appreciate that the risk of infection and the risk of herpes zoster is something which is concerning. Otherwise, the other risks like malignancy and lymphoma are equal to the biologic disease-modifying anti-rheumatic drugs. As far as the DVT is concerned, there is also a frequency of pulmonary embolism is seen. Mortality with tufasitinib of 10 milligrams BID, which is not actually recommended in the treatment of rheumatoid arthritis. Only 5 milligram twice daily dose is recommended. And there is the European Medicine Agency has recommended that the tufasitinib should be used with caution in patients with known risk factors for VTE, including history of cardiovascular disease, obesity, cancer, hypercoagulability, coagulable states and history of prior VTE, as well as patients on hormonal contraceptives or hormonal replacement therapy, patients undergoing major surgery, or patients who are immobile. So these factors actually help us to decide whether your patient is a true candidate for the JAK inhibitors or not. So in summary, the JAK inhibitors are rapidly developing treatment space in rheumatoid arthritis. They offer a targeted oral therapy with comparable efficacy to tumor necrosis factor alpha while maintaining a similar safety profile. JAK have been incorporated in the ACR and the ULR guidelines for the treatment of moderate to severe rheumatoid arthritis, which is refractory to methotrexate or other biologic therapies. For patients with difficult to treat RA, personalized approach is the key. And JAKs will be increasingly used as prescribing. This is anticipated that the JAK inhibitors will be increasingly used as prescribing practices change with long-term safety and efficacy data. Thank you very much for your patience, and I would be happy to take any questions.
Thank you very much. Due to the constraint of the time, we will take the question answer session later. We start the next session, and this session is how to do it, tips and tricks. And the first presentation is by Dr. Ramesh, estabulum in and out. Please start.